Land is really meshed together like acid. So land, which one is that? Oh, okay. So you do a posterior approach. So this line like this.
Book is written there 1 centimeter back to the edge of the credit.
Do you know one thing?
No, the incision should start 1 centimeter.
Yes, that's same. So if you start 1 centimeter behind, this is the middle cutting edge. This is 2/3. This one thing. Yes. Okay, guys.
When we talk about the sense of rotation, the cup is lateralized too much. There is not increased chance of dislocation. You may not need to go back and lean more and put the cup at the right place.
If it's lateralized too much?
The cup is lateralized.
Yes, but if you pick it up before that, while you remake and you try to pick it up, yes, you got to go further.
So your recommendation for attachment of short extremity?
I don't do that. You don't do that. As I said, in the PSM, there have been studies in which what they've done is they put radiopaque markers. You prepare the rotators back on, you put an opaque marker through the IOACON.
24 hours, everything comes out.
Like that. You measure the distance between the two. 2 weeks later, you X-ray them, that distance has gone up.
You only repair the capsule. Capsule repair.
You could if you want to. Capsule is too flimsy, especially in trauma, which we have. If it's osteoarthritic, it's going to be thick. In our fracture patients, it's too flimsy. Capsule is normally very thin. A few millimeters thick.
So how do you close? So how do you close your wounds then?
No
capsule, just the.
Yeah, go straight away.
Straight away.
Okay.
Quick in, quick out. Oh, that's for the asthma. Yes, I'll take it out.
And this one thing I have to ask, your external, you remove this medicine at point. Cut them, are you switching them back?
No. You switch them, they'll come out. The switches come out.
Many people like I had seen, they were suturing them back, in my medical college.
That's what makes sense. You could switch them back. But there is no evidence to confirm that that's stable.
And you talked about some retractor putting it through the piriformis.
No, what I said was, this is the medius. And these are the you find the retractors. To make sure you're not cutting your protective medius. That's the whole idea behind distribution. So put a hummus there.
What care are you taking for the sciatic nerve which is going through the piriformis muscle? Underneath it goes piriformis muscle.
Yeah, but that's fine. Yeah. The studies show you can do up to 6 centimeters. 6 centimeters. What you should do is once you've done that, in the post-op period, when you go into it, keep the knee flexed. Post-operatively, keep the knee flexed. Don't let it extend. So keep a pillow under the eyes. If it's exontimosis,
Yeah, no, that's not what he actually is. It just skids
depending on
around.
what he has. If he's got foot drop, then you do tendon transfer. Obers and bars. You know the obers and bars. Obers is when you take the posterior through the trusting membrane part through. Bars you take it out.
What about low?
18 months. You've got to give it 18 months. You've got to wait 18 months. Because the nerve generates 1 millimeter per day.
In a revision situation, when you use the wedges and things, you
And the distance between the foot and the hip.
between the wedge and the shell. Yeah,
Sir, one question, sir. There was one patient whom they did THR. The graded point was fractured. So they did a circulation wiring.
Inside a shell.
Fusion, they went through this process.
It's pretty desperate.
Should we go underneath that or we should go
Under the lesser.
There's no option.
That cause corrosion.
tension?
That cause corrosion.
One more question, sir. That's,
Oh, they do
people go through the medial cortex. They won't touch the step to the medial
They have a
cortex.
special
This
flank.
is the right thing. You said it should be neutral.
Anatomically designed.
Yeah. So if I do a section through the tip,
We don't have the evidence. And you're using extra reamer.
because what happens is, I'll tell you why. If you have a touching in the cortex there, so if I have a stem touching, this is the cortex, the stem is lying alive. So when it osteolysis, it takes that cortex, scalping.
No, only the anterior. Because that's the one that's going to
They are always fighting for their own case only post-operatively that they should touch, and when it's like this, they are not happy with it.
Yeah, if you want to.
Yes, no.
I don't worry. Because the posterior one's going to help you recover. Because when you constantly recover, the posterior aspect sticks out.
If you say that the
This
structure level
alone will be for bipolar also the same thing, or you will only say it for cardiac?
both should be neutral. But of course, in case it all on each side, you can accept 5
No, the cup goes where you put it.
One question. Intraoperatively, we have to reduce the normal offset. So this you do on the basis of preoperative templating, exit operative.
and intro.
And intraoperatively, again you have to routinely
Very
measure.
interesting. Very old. So you expose the hip there.
Personally, no.
This is what you expose it from the back. This is the front. Suppose they expose the hip from the back.
Your patient
Take a length of the scale
a couple of weeks later.
from the trochanter. That's how I had cautery. Center of the head. That's your offset. Measure that. And that's what you reproduce.
Only horizontal, also vertical. Unless I trochanter to
Yes. Well, normally, if you reproduce this, this normally reproduces because again it's a hypotenuse.
so pre-op templating is X-ray templating.
Have we got any
Intraoperative.
Any role of centralization?
It's there. To be careful. No, we get it. Just pass No. See, there are 3 things. Okay, so this is your rough. There's one head here, there's one head here. Okay. So you've put one line through this. Okay, one line through the teardrop. So 2 lines in the pelvis, one in the femur.
One through both the tuberosities.
Yeah, could be lesser, could be greater. Yeah, so you take lesser. Lesser is better because that's what you measure your leg length from. So you take a length from here. This is important to get 2 leg lengths, one in the pelvis which is fixed, one in this, and you measure the leg lengths. So this is first part of pre-op templating. After you measure the leg lengths out of the way. So you say this leg, because of arthritis, is half a centimeter short. So leg length discrepancy is half a centimeter. You put it onto the board, your operating board. Then you say, after you measure, what is the center? Where is the center of the head? Okay. You can't do the hair. This head is deformed. You won't contract the side. You see the center of the head is here.
Many patients come.
Yeah, you can do that. You can do that. Yes, by that you can do that. But that you need templates. I'm just doing it on the X-ray. You haven't got the template here. So this is only marking the body landmarks. Yeah, so we done this. So then you mark the center.
So what all landmarks you mark, sir? Pitch of the head?
So here, so one line is the center head.
Yes.
Center head line there. Okay, this line is not always parallel because the center head could be here for a patient who's got the head there. Yeah, so this line could be like that. So this is the first line is the gradient on the pelvis, second lesser under the femur. Measure leg lengths. That is out. Then measure teardrop lines.
just put this guide and you can make your लेसर ट्रोकैंटर इसमें है ही नहीं. Let's just presume कि this is the ये यार अगर यहाँ होएगा ना तो neck का तुम्हारा base of the neck पे जाएगा. That is not the area. Your neck cut is in the trochanter. Let's just say कि this is the lesser trochanter line. ठीक है. These are not exactly right. So about one finger breadth above this. This is above the lesser trochanter is 1 centimeter, 1.5 आता है actually. But मतलब you don't need it to vary. So this is the neck. Now you can mark it. Pen. Just mark it with the pen. This is the level of your neck. ठीक है. अब कौन कट लगाएगा? This thing you can slide under the fascia and then you can just position it and cut it. ये पकड़ लेना यार हिले. Just hold it with one hand solidly. This you need to hold with both hands. वो खड़ा हो जाएगा. You don't have to cut the trochanter. यहाँ ले. ठीक है. Now to get an approximate idea of the size of the astrolum, you can size the head. So you have 2 to 4 millimeters. Just approximately if you need it, otherwise not required. Okay, so now you taken the neck cut. It will be little bit. Astrolum तो बड़ा होगा ना. Cartilage का आप 2 millimeter cartilage head का 2 millimeter cartilage astrolum का 4 millimeter बड़ा होगा. Diameter wise it will be 8 millimeters. Next, no, box chisel. Box chisel का.
Sir, it should be just above the lesser trochanter.
Lesser trochanter, 1 finger, ideally. But you can use this guide. Now this is a box chisel. Now the aim of the box chisel is to remove bone from this trochanteric area. Now what you have to do, you have to make sure that you are entering laterally into the trochanter. What happens is that the bone out here is usually sclerotic. So you have a tendency of entering into the most easiest part, that is the cancellous area. Now if you enter the cancellous area, your implant will tend to go into varus. So to make it to go into neutral position or in valgus, you have to remove this hard bone. It might require a lapel or hammer. So just take this like this. ठीक है. इसको इस पोजीशन में कर करके करो. हैमर लो. हैमर है. टूट ना जाए. The only thing I'm concerned about. If you're not very comfortable, if this is very hard, make a couple of drill holes into this and then.
Level it with level.
थोड़ा सा ऐसे. You have to just see the surface of trochanter. ये है ना. You have to try and go parallel with the first cut. You have to hollow out this area.
आप सर वर्जन भी मेंटेन करते हैं क्या?
इसमें वर्जन का कोई यहाँ से वो तो ब्रोचेस पे डिपेंड करेगा ना सर. अभी तो आप गड्ढा बना रहे हो बस.
गड्ढा बना रहे हैं.
सो इट हैज नो रोल विद द वर्जन. बट उसके बाद छोड़ दो. ध्यान तरह दूसरा लगे. सो लेट्स जस्ट से कि वी मेड दैट थिंग. नाउ यू हैव स्ट्रेट रिमर. नाउ स्ट्रेट रिमर इज फॉर 2 things. To make the initial entry hole into the canal. The second thing is you do not hammer this, you do not drill this. Because if you have a very osteoporotic bone, or if you have a little bit of deformity, or if you are entering from a relatively middle side, you will tend to perforate the anterior or the lateral cortex. So you have to be free hand while putting in the reamer. So यहाँ से लेके आप free hand आप reamer से enter. Now you are in the canal, right? And you can move it this way and this way to find.
We should not, rotate it. We should go directly.
Ream करके जाते हैं. हाथ से manual reaming बिल्कुल. It should not टूट जाएगा पूरा. It should not be with a hammer, it should not be with a drill, because you have no idea how much force the drill is applying and you just might tend to perforate, especially if you are entering on the middle side. So it is very important that whenever you are doing it, you have to try and lateralize your hand. The best way to do it is initially with the box chisel and then you use subsequent increments of the reamer.
We remove the lateral wall, sir. We should remove the lateral wall.
You are not removing the lateral wall.
The tendency
Posterior superiorly,
to the lateral.
the posterior superior of the greater trochanter, the bone is very sclerotic. So that's why you have to hammer it out. जिससे कि वो valgus या neutral में जाए, varus में ना जाए. If you are putting it from here, then the implant will go like this. See, this. If you are putting it from here, this is how it will go. So this is varus. You have to try and put it like this or a little bit like this, valgus. तभी वो survive करेगा. ठीक है. Once your bone, this reamer starts to touch the cortical bone, then the time when you start with the broaches. This is the handle for the broaches, and these are the broaches. You can just open it up, attach the brooch and close it. This is the smallest size of brooch. Starts with 8 for a corail. Okay? And now start. Now you start.
You are
and you have to maintain anti-version maintain करना है.
ये एंटीवर्जन कैसे करेंगे?
When you have because the bone is a solid structure, it will automatically go into that version.
ठीक है, टीबीएस से टीबीएस से पता चल जाएगा इस समय.
नहीं, go in the direction you are going and then slightly turn it away from the lesser trochanter.
Yes, sir. Go in front of them.
You got it? Lesser trochanter is posteriorly. If you turn it towards the lesser trochanter, you will be putting it in retro-version. कोरेल का फायदा क्या होता है कि as you keep on increasing the size of the broaching ना, it automatically goes in the direction of the femur, the natural anatomy of the canal. So it will go in the right direction of the version. So you really don't have to take care of the version. Version को आपको ध्यान रखना पड़ता है when you are doing a cemented hip because it is a smooth thing, and when you are doing a solution stem because solution stem is rounded, so it tends to rotate in any direction. So you have to put in a small Allen key or something to keep the version.
So you are demonstrating that.
इसमें usually नहीं देखना. By the time you are reaming,
you are demonstrating the uncemented one.
This is an uncemented
one.
Yeah, उसके broaches है. So once you broach, now how much to broach? You have to enter up till this line in the line with the trochanter. ठीक है? Now how do you know कि which is the correct size of your broach? Once you are hammering in the broach, you will have a particular noise that will feedback that will come to pitch जिसको हम कहते हैं. But once you are reaching the right size, the pitch will change. It will suddenly become solid. Instead of being a little bit hollow, it will become a solid pitch. And that is when you know कि you have reached the right size. Now your final corail implant is thicker from the broach by about 0.3 or 0.31 millimeters.
Marking is the same.
साइज सेम होता है सर.
साइम 8 का 8 ही
कोटिंग होती है ना,
जो लिखा होगा वो 8 लिखा होगा उसमें. दोनों के पे जो लिखा होगा मार्क होगा वो इस पे ही 8 होगा.
सेम साइज 8 will correspond.
लेकिन उस पे
the final implant will be thicker by 0.3 or 0.31 millimeters because of the coating of the HA on it.
Right.
They coat it with a very sophisticated technique called grit blasting, जिसकी वजह से thickness बहुत ज़्यादा नहीं होती, but HA coating हो जाती है, उससे बढ़ जाती है thickness. So it will be even a better thing कि जो आप broach कर रहे हो उससे थोड़ा सा मोटा जाएगा finally, and you have to seat it up till the.
So this is anti-version correct?
This is you have to. अगर कोई भी डाउट है तो err on the side of anti-version than retroversion. Retroversion is disaster. तो ये version normal जा रही है. Can you see I had fixed it in a little bit of anti-version when this thing was intact. मैंने उस टाइम देख के इसको fix करा था. And can you see the anti-version on this? This is about 15-20 degrees. अब ये देखो. This is neutral version. और मैं इसको और मोड़ूंगा तो रेट्रो वर्जन हो जाएगा.
नहीं ये तो आपको रेट्रो वर्जन होगा.
ये तो ये आपका एंटी वर्जन है 20 डिग्री.
नहीं ये अब जो आपने चेंज किया था वो तो एल्टी
वो न्यूट्रल वर्जन आ गया था.
वो लेटरल की तरफ नहीं लो आप लेसर ट्रोगेंटर
की तरफ टिल्ट कर रहा है.
लेसर ट्रोगेंटर में कहाँ पे है?
ये यहाँ पर है.
ये
यहाँ पे
इस पोस्टोमीडियली ना.
तो उसके एंटीली
अब ये सर एंटीरियर सरफेस है. वो एक मिनट हाथ हटाना प्लीज वहाँ से. कैन यू सी दैट फीमर एंटीरियर सरफेस ऑफ द फीमर? तो दिस इज द एंटीरियर, दिस इज द पोस्टीरियर, दिस इज द मिडल, दिस इज द लैटरल. So you will turn it a little bit this way while broaching. But increments of the size of this thing will automatically go into anti-version. You cannot go wrong. So that is one very major advantage of anti-version.
When we are doing a cemented one, then how will you maintain this one? This version.
That comes with experience. You have to anti-version it. When you
I rotate the stem.
Anteriorly. Yes, that is right. Actually, अगर आप anterior पोस्ट से आए तो anteriorly rotate करनी पड़ेगी.
Posterior पोस्ट से आते हैं.
Away from the lesser trochanter.
हाँ, away. Anterior to the lesser trochanter. LT.
Yes, anterior to the lesser trochanter is absolutely right. So with that way you cannot go wrong. Plus then this is the trunnion. आप इसको attach कर दो to a trial reduction. We don't have the implant, so इसी पे attach करना पड़ेगा. लगा दो इसमें. Put it in. Put in a trial head. Corail के sizes come from plus 1.5, plus 5, plus 8. Internationally 12 तक भी आते हैं neck length.
Plus 1.5.
Plus 5, plus 8.
कितना
इंडिया में 12.5 तक आता है. मिलीमीटर्स में है ये सर. The shortest neck length that means is 1.5. उसके बाद neck length 5 millimeters है, then 8.5. So you want to increase the vertical offset, you can increase the neck length.
That is inbuilt in the head.
This is inbuilt into the head.
And how can we adjust the leg length? Leg
The
length.
horizontal offset.
No. I want to suppose there are two parts, the stem part and the head part.
हाँ.
And if you bury more,
तो आपका लैक्सिटी बढ़ जाएगी ना, पैर छोटा हो जाएगा फिर. अगर इसको प्राउड छोड़ोगे तो पैर लंबा हो जाएगा. और अगर उसको बरी कर दोगे
there
तो
are
short हो
options in
जाएगा.
this part also, no?
इसमें ऑप्शंस नहीं है, बट यू हैव अ स्टैंडर्ड ऑफसेट एंड अ हाई ऑफसेट नेक इन कोरेल, जिसमें आप मीडियल ऑफसेट बढ़ा सकते हो. एंड द अदर इज
अगर आप गलती से ज़्यादा बरी कर दिया आपने तो क्या होगा? उसमें बढ़ा सकते हैं?
हाँ, बढ़ा सकते हो.
उसमें बढ़ा सकते हैं.
यस, नेक लेंथ बढ़ा दो ना. अगर आपने 3 मिलीमीटर ज़्यादा बरी कर दिया तो 3 मिलीमीटर नेक लेंथ बढ़ा दो. 1.5 की जगह 5 डाल दो, बराबर आ गया आपका. और अगर आपने बाहर छोड़ दिया है एंड यू पुटिंग अ नॉर्मल लेग लेंथ, फुल वेट बेरिंग चला दो, 2-3 मिलीमीटर सिंक कर जाएगा, बराबर हो जाएगा. सो इट इज बेटर टू एयर ऑन द साइड ऑफ
मिडिल साइड की
क्राउड रादर देन बरीड.
डॉक्टर मारिया बता रहे थे कि यहाँ पे जो कैंसरस आपका
Yes, that is to prevent debris from going into it. So जब box chisel से आप निकालते हो ना हड्डी, उसको रख लो, यहाँ से निकाल के उसको रख लो, put it here and use a small punch to hammer it. Or you can, if you don't have that, you can use your head to put that.
सीमेंटेड में की लगा के देखते हैं.
अच्छा, सीमेंटेड जैसे मैं यंगर
Last question, last 2 question, okay?
सीमेंटेड जो स्टेम डालते हैं उसकी नेक लेंथ अगर डिसाइड करनी होती है, उसमें की लगा के स्टेम को
नहीं, वो ट्रायल में होता है की लगा के जब करते हो. उसमें देयर इज अ स्मॉल दिस थिंग सॉर्ट ऑफ एन एलिन की दैट इज पुट इन देयर टू फाइंड आउट कि आपकी ट्रायल रिडक्शन के लिए टेलीस्कोपिंग हो रही है. एंड अकॉर्डिंग टू दैट यू हैव 3 मार्क्स ऑन द फाइनल डेफिनेटिव एग्जाम. पुट इट अप टू दैट लेवल. हाँ जी.
बॉस, मैं पूछ रहा था कि सीमेंटेड स्टेम अगर यंग इंडिविजुअल में की है और उसके लिए अगर रिवीजन की जरूरत है तो
ETO करके खोलना पड़ता है. You have to do an extended trochanteric osteotomy. You have to open up the whole trochanteric to the level of the distal part of the tip. You have to remove the obturator also. जो hardening restrictor डाला होता है वो भी निकालना होता है. तो you have to do lift up the whole flap, remove the cement and everything, and then put in a distal fixation stem and then rewire the whole.
इसीलिए बहुत ज़्यादा अच्छा है कि अनसीमेंटेड पहले की जाए.
नहीं, ऐसा नहीं है यार. It is ऊपर वाले के हाथ में कि क्या चलता है क्या नहीं चलता.
Just I want to know about.
The non-cemented
Okay, forget the cement, non-cement. What is the best type of implants for her?
Sir, if the patient is physically active,
She's very active.
if she is active, then I'll
She
fix
likes
it.
to drink. So this happened while she had a few drinks, okay? But she does her shopping. She's very active. She doesn't look like she's 80. She looks young.
Right. Then probably I'll fix that fracture.
Okay, that's an option. You could fix the fracture. It's not a great looking pattern. So alcoholics. So what sort of bone do they have? What type of bone?
Osteoporotic.
So osteoporotic. And what else happens with alcoholics? What else do alcoholics do? They fall over a lot, don't they? And will she non-weight bear or partially weight bear?
Partially weight bearing.
But she's an alcoholic. They're going to put full weight on them. So what other operations could you do for her then? So you've had a hemi, we're going to do total hip replacement. Yeah? Everyone agree? You're all happy? Yeah? Everyone's going to... She's 50. She's 50. Okay. So, well, yeah, okay. So which approach? Come on, it's your case, guys. Which approach do you want to do? Give my hand over. You do a posterior approach. Okay, I think it's not unreasonable to do the lateral approach because her hip is very mobile. She's not going to do what you say, okay? So when we do the posterior approach, they've got to get up, the legs abducted, externally rotate their legs. We don't let them flex their hips. So when they bend down, they put the good leg, the operated leg behind them. With a direct lateral, you could probably mobilise them a bit quicker, okay? So you might choose a direct lateral, okay? So what do we think? So she's got a cemented stem, okay, looks very nice, doesn't it? She's got an uncemented cup. What do we think of the cup?
It's a bit vertical.
Okay, good. So the cup is, so if we draw our line between the teardrops, okay, horizontal, and then we draw, we're looking at Sharp's angle. She's got quite a shallow acetabulum, hasn't she? So it is, haven't overreamed, but you do wonder, is that cup stable? It is quite vertical, a big head. If there's polyethylene in there, it'll be very thin polyethylene. We learnt about thin polyethylene 20 years ago. It's not good. Anyway, she's happy. So, are you happy, surgeons? Are you happy, surgeons? Yeah.
You're not having more needed here.
Huh?
You're not having.
Well, maybe. I didn't do the case yet, so she hasn't come to me yet. But maybe. Okay. So off she goes. Do you want to pass the microphone back now? It's your case now. So then, as we said, alcoholics, they fall over a lot. So next slide. So she's back in about 4 months later. Do you want to describe the X-ray?
So the cup must have been put more vertically. That is why it is displaced upwards.
What's going on? What do you think she's done?
So she must have fallen down, or must have picked up something, or bent forward to pick up something. That is why
she had another fall. I think. Well, she fell. I think. So it looks like there's something going on here. Okay, so well done. Looks like she's fractured the posterior wall. And what's happened to the cup? Okay, so what are we going to do now?
So revision.
A revision. Okay.
Revision with.
But tell me about.
Revision with a more horizontal cup and probably with a screw fixation.
Okay, but what? Okay, we've got a piece of posterior wall has come off. Yes. So what other problems are we going to encounter now at surgery? We've got a plan or operation.
Yes. So we'll have to restrict. So we'll have something to support the posterior acetabulum.
Okay, it might need fixing. Good. Okay.
So or
how do we do that then?
Or cage could be put there to.
Cage. Okay. If your posterior wall, part of your posterior walls come off, you've got an incomplete defect. So you've got peripheral defects, you've got cavitatory defects, you've got medial defects. So we're going to have a peripheral defect, aren't we? So cage may not be needed. What else can help us decide?
Bone grafts.
But for our planning, a CT. Okay, why don't we get a CT? Okay, AJ magically gets a CT for us. Thank you, AJ. And okay, does that help us? Looks like quite a big chunk, doesn't it? Huh? Well, fix it. Okay, so we're going to reach for the how are we going to fix it?
Reconstruction plate.
Yeah, a contour reconstruction plate. What I like to do is get a model, a pelvic model, bend the plate on the model, and then sterilize it, and then it's ready. It saves time. Okay, try and get a couple of screws below and a few screws above, and then we've gone back to our acetabulum. It's intact now. And then what would we do? What are we going to do for the acetabulum next? You could do a cemented, you could do an uncemented. If you're going to do an uncemented, you're probably going to need a lot of screws, okay? And you might use trabecular mesh, okay? So pass the microphone along. Okay, so what about access? Right? This is sitting in the way, isn't it? We're going to go posterior approach, but we've got the stem is in the way. What should we do about the stem? Huh? Anybody? How can we improve our exposure so we can see everything? Posterior approach, but there's a stem. A femoral stem is sitting there. Yeah, you obviously dislocate it, but have any of you used these polished stems? So the more the patient walks, the tighter the stem is in the cement. But if you get a blunt osteotome or a slap hammer, you can just knock it out. So the stem comes out very easily, and the cement mantle is intact. Okay, so it's modular. If this was a cemented stem, if this was an uncemented stem, like a corral or whatever, it's not coming out, is it? It's fixed, very difficult. And that's why I like doing the cemented stems. And then at the end of the case, I'll just put some more cement in the mantle and put another stem back down. Very easy.
Downside the stem.
There's a special shorter stems you can use. So you keep the offset that you've heard about this morning, but it's shorter. Are you all happy with that? So I've got so many options now. Honestly, it's getting easier. So just good to know about these things. So if we can have the next slide. Okay, so this is what we've done. You can see the original stem went down to here. So we've got a shorter stem, but we've knocked out the stem, and then it was a big fragment. We pushed it back with 2 screws, okay? And then this is a buttress plate along the wall, yeah? And a couple of screws below, a couple of screws above, okay? And then there's cement there, and a cup, a small cup. So we've got much thicker polyethylene, and then we cement in a shorter stem. If I can have the next slide. So you can see the difference, but the offset is the same. Okay? Happy with that? Slightly unusual case, but you're using different techniques for that particular problem. All right?
You have used a Cocker angle.
Yeah, absolutely. Yeah, Cocker angle back. But you need that because you've got to get right up the column and see everything.
So in this, can we use a Proxima Proxima stem, that stemless one, Proxima?
I think that Proxima is an uncemented, small, stubby stem.
No,
and you're doing
you've
it.
got cement. You have to take all the cement out. It's too difficult.
Or can we modify it? Can we use Proxima with cement in it?
No.
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 Because the Greater Trochanter has so much space in
No.
it.
No, you can't.
You can't.
Because it wants bone ingrowth, doesn't it? It wants ingrowth. There's no need. This is cheaper.
Because the Greater Trochanter has so much space. The Greater Trochanter to Lesser Trochanter.
No, but this has all got cement, you see.
Yeah.
No, don't confuse it. No, we won't mix the implants. Okay, so let's move on then. Let's have another case. Right. So you all recognise this, yeah? Who's got the microphone? Tell us, yeah? Your turn. No?
Yeah, that's fine. You
can
can
hear. Pass it forward to this gentleman. Yeah, tell us about the case.
Protrusio acetabular.
Yes, okay. So there's your hemi. What stem is this?
Is it Austin
So you still have
Thompson.
them here, yeah?
Thompson
They've
stem.
been banned. These are terrible stems. You can't get them out. You've got to get under the collar, and it's curved like a banana. But anyway, so this is quite an elderly gentleman, and you can see he's driven it into the pelvis. Okay, so what problems? What do you want to do, sir?
Revision with
Well, talk me through.
with total
I'm
hip
the patient.
replacement.
What are you going to do to me, doctor?
Total hip replacement.
Okay. What steps are you going to take? Dislocation will be difficult. Good. So your pre-op planning. You've got to try and dig that thing out of the pelvis. Huh? We got a deficient medial wall. Well, look, you're all hung up on the medial wall. Charlie used to regularly make a hole in it.
The cement is there.
Okay, but we're going to do grafting, aren't we? So we need to get some graft from somewhere. So in the UK we use a lot of frozen femoral heads from primary operation, and then we grind it up so it's particulate graft, and we pack it in, impaction bone grafting, and that's what we would do for this case. So impaction bone grafting was first described for protrusio acetabular, okay? So it's great, it's dead easy, don't need any special kit. You can get a mesh, and you can put your mesh in the floor if you've got a big hole, and then impact onto the mesh, and then cement and a cup, or you could do uncemented, okay, if there's a good rim. Okay? Are you happy with that? What are we going to do about this stem?
Jumbo head.
Jumbo, sorry?
Can we put a jumbo cup?
A jumbo cup. You probably wouldn't need it. Keep it simple, huh? Probably not necessary.
Would you like to fix the mesh?
No, with a medial defect, you don't need to fix it, because you have a hole and you put a larger mesh in the hole, so it presses against the bone that's intact around the hole. And then you pack your graft and then you cement. Okay? There's no need to fix the medial mesh as a rule, unless it's a huge hole. But what are we going to do about this? So we're going to have trouble dislocation, so big approach, okay? Make sure we see everything, we carefully try and pull it out of the pelvis. And then what do we do with the stem? Are we going to leave it in or knock it out? What is it? Who's going to remove the stem? Hands up, all those who are going to take the stem out. Hands up all those who are going to keep the stem. How are you going to, but look at the size of the head. The head's about 55 millimetres. How are you going to get something to articulate with that? Just knock it out. It's easy. And then you've got cement. We can cement another stem into that cement. It's easy.
Cement or cement.
Yes.
Yeah.
Perfect bond. Very straightforward. Very simple, very cheap.
But if you find certain loose cement particles,
Remove them.
You have to
Yeah, well what you should do, you knock out the stem. First of all, you'd examine the, I mean, you know, it's not perfect for cementing cement. This is an elderly patient, okay? It's an elderly patient. So ideally, you need good cementing, okay? And what I tend to do then is block the canal, maybe with a little swab, so no particles go down. I might remove some of the cement around the top, but you need good bone stock and an intact cement mantle, ideally. But we do it more and more. Very simple, quick option. Because most of the problems are acetabular. If you use this polished, cemented stem, they don't come loose. So most of the problems we see now are on the acetabular side. And remember, if you argue about cemented or uncemented cups, loosening of a cup, cemented or uncemented, is a long-term problem. So you shouldn't see it for at least 10 years. Okay?
This cement looks like loosening in these.
Yeah, agree. But he's very old, this guy. I think he's early 80s. Okay, but we've got the principles. If you're unhappy, remove all the cement and then do an uncemented revision or whatever you would like, a longer stem. Okay? But I show this case just to focus on the acetabulum. Okay, let's next slide, please.
The greater trochanter is osteolysis of the greater trochanter.
Okay. No, well, it's maybe. I mean, it doesn't look it there. So I've cemented back in. You can see it looks quite nice now. But I want to focus here. So I've got a strut there. Okay. So I've got a femoral head, and I've cut a piece and I've pushed it there. And this is all graft. Large volume of graft. Sorry, it's a poor X-ray. Sorry? It's from a primary hip replacement that's been donated and tested and frozen. Allograft, so I'm a bone bank. Next slide, please. Wrong way.
You have not used a mesh?
No, there's no need. This is bone. This is a piece of bone. And this is 4 years later. It's looking okay, isn't it? The stem. That's just the standard primary hip replacement stem that I put back into the Thompson thing. Okay? So acetabular protrusion, it's very straightforward. Okay? So if you want to read about it, look up the impaction grafting papers, particularly from Nijmegen, which is in the Netherlands, Thomas Sloot. Then they've got over 20 years experience with that technique. So are we happy with that? Okay, so you all like the Austin Moore?
No.
Huh? No?
Yes.
I have a patient, she came back from holiday in India, and while she was on holiday she fell over, and she got a neck of femur fracture. What happened next? Austin Moore. No, and then what happened to the Austin Moore? No, it broke. Guy, you're very clever, okay? Oops. But it's not just an Austin Moore. What has the surgeon done? He cemented it. So probably put it in and it was loose. You go, I know, I'll put a bit of cement in. Okay, so we're getting a bit outside of today's remit, but what are the principles now? So how about the back row here? Do you want to hand the microphone back? Go back, and then back one more. Right, so how do you want to tackle this?
So post-hoc ways of AMP arthroplasty with implant failure.
So what's the plan?
Primarily, first we have to extract the implant. That the process should be.
How are we going to? Okay, well, first of all, we probably should exclude infection with all these cases. Okay, but we'll for the purposes of this, it's not infected. Okay, so you're going to extract the implant. How are you going to do that?
ETO.
ETO. What's it? Do we know what an ETO is? Would you like to tell us? Who said ETO?
Extended trochanteric osteotomy.
Okay, that's the easiest way out. And certainly if you've got problems with a uncemented implant, I would go with an extended trochanteric osteotomy. You've not seen that? You've seen the pictures? It's a very useful technique. There's a number of ways of doing it, but essentially you're going to remove the lateral half of the upper femur, keeping the abductors intact here, so you can do multiple drill holes, okay, and then connect them with a sharp, thin osteotome and lever it back carefully, the piece of bone, okay, and then you get excellent access. But again, preoperative templating, so we want to work out how far down we need to go. It's a very safe option. And then, pardon?
Not use a saw.
Well, some people do. Some people do. I like to do drill holes and an osteotome. So you get a fine saw that you cool, okay, that you irrigate, and then you get at this very quick and easily, okay. You can take this out, chip around the cement, and carefully, and extract it. So then what?
How far osteotomy you will do for all?
I think I went probably about here.
6 inches.
Yeah, I don't want to get. If you go beyond the isthmus, you know, you start having problems. But I would. You can go there, but I would go about here. Okay. So then, what do we do? Back row. What are we doing now? Do you want to pass the microphone along? What would you want to do now? So we've done an ETO. Got the stem out and the cement. What do we do next?
Do a total. Hello. I do a total hip.
Do a total.
Total hip.
Yeah. Well, tell us about the principles.
Distal loading step.
So we're going to have to go distally, aren't we? So our fixation, we've got an osteotomy here, which we'll wire, but the teaching is to go at least 2 or 3 diameters beyond the defect, or beyond. Okay, so you're going to need a longer stem. Okay, you could go cemented, you could go uncemented. The easy way are the new uncemented modular revision systems. They're very simple to use. Okay, so you'll get your fixation here, and it will be some kind of tapered system based on the Wagner principles, titanium, as it tapers down, conical, possibly with flutes, and those things really stick. You can't get them out once they're in. And then the proximal body is modular, so you can have as much. You can lengthen, you can do your offset, you can adjust your anti-version. You know, totally modular. Okay, but what's the problem with modularity of these systems? Each interface can be a source of corrosion. Okay, now in this patient we won't have to worry about that.
So one small doubt, sir. In this case, after the ETO, like if we do cementing, like is there any problem with if the cement seep in the inside
practice,
gaps?
No. Particularly if you put your ETO back very carefully. Okay, and then you can get good pressurization. So they've got a large series from Exeter that they've done. Most, certainly in Europe, would go uncemented. So, I mean, you know, the early results are quite good. She's early 80s, this lady, so I wouldn't worry too much about long-term complications. I'd be more worried about infection, dislocation.
But we should do a long stem?
Yeah.
Uncemented long stem?
Yeah. Yes, absolutely.
Cemented one is not reprinted.
Sorry?
The cemented?
You could go either. I do it both ways.
In cemented, we cannot pressurize the cement.
You can, why not? Of course you can. You put a plug in and pressurize it. If you've done a careful extended trochanteric osteotomy, it fits snugly. So when you make the cuts, they slightly beveled. Okay, so you've beveled the cuts so the bone sits back snugly. Okay, so you can pressurize it. And the polished stems come in lots of lengths, up to 240. So you can use whatever. I don't think it matters whether it's cemented or uncemented, it's the principles. Okay? So you're not going to get surprises. You're going to plan it carefully, select what you need. Okay? Are we happy? So what about the cup? You could do whatever you like, but we want to be careful with our reaming. So we don't want to ream medially, okay? But we'll probably ream up
sir,
here.
I want to say that cement will come out from the osteotomy side.
Pardon?
I think what will come out from the osteotomy side.
Where? In the femur? Yeah. If a little bit comes out, I wouldn't worry too much. It really wouldn't worry me. I'm using a polished stem. So the longest tapered stem is 205, which would certainly be longer than this. Would get me down to about here. And as I said, your cuts should be beveled. So the bone really does sit quite flush. Okay, you'll see the close-up picture.
And the stem should match the anatomy of the femur. The femur is a curved anteriorly.
Yeah.
The femur is curved.
But this is an osteoporotic femur. It's a big drain pipe.
The lower end of the stem may perforate the anterior cortex.
No. If I was going for very distal fit, and I was using a modular uncemented, they are curved. So, but in practice, it's not an issue. Okay? Well, is there any need to fix the ETO? Yes, I would. I mean, previously we were doing 3 or 4 cerclage wires. Now, 1 or 2. 1 or 2. And maybe a prophylactic cerclage wire down here. Because when you put these stems in, the uncemented stems, you can get a fracture. Okay, so you don't want that. Alright, and then the cup, you can do whatever you like, uncemented. Personally, osteoporotic fracture, I would prefer cement. It's just a bit easier, less likely of a fracture. Okay, so should we have a look what we did? So we've done a cemented cup, okay. Here we have our extended trochanteric osteotomy. So you can see it's quite snug, isn't it? You'd hardly know that this lady had had an ETO. And then we've gone distally. We've got a nice fit here with our tapered stem. There's the modular bit. So this bit comes in so many different sizes. You know, you can custom make it according to your patient. Okay, it's very flexible, very powerful, easy way of getting out of problems. And then there's a prophylactic wire, and this is the fixation. Probably too many wires, but okay. She was quite elderly. She was still mobile, shopping up, but she was, I can't remember, about 80.
Weight bearing?
Huh?
Weight bearing?
Oh yeah, full weight bearing. Absolutely. I rarely non-weight bearing. Even if you do this, you get huge forces going in the hip joint, don't you? Everyone has to weight bear.
Does the ETO, but what are you for a weight bearing?
No, fully weight bearing. Fully weight bearing, yeah. It's tight fit, isn't it? It's not going to come loose.
The multiple encephalous wires only has for the blood supply prone for
the large series of ETOs, someone the south coast of England had, I can't remember, 130 cases, 1 non-union. It's the femur. They tend to heal. It's a large surface area. They heal. Okay. All right. We happy with that one? I think we might have time for one more. 5 minutes. Yeah, one more. Yeah. Okay. So we heard one of the big themes of the day is pre-op planning. Okay. Apologies about the X-ray, but this is a 48-year-old lady. She's about this tall, but this wide. Okay. Otherwise fit and well. And she gets this neck and femur fracture. Now it's a poor X-ray, but she's got very thick cortices. So this would be a door type A. And remember what we said about the door type A? Very narrow canal. Okay. So how are we going to manage this case? So who's got the microphone? Where's the microphone? So let's finish this case on this side of the room. How do we want to manage this? She's 48. She did this while she was out shopping. It's a neck and femur fracture. You manage these every day. Huh?
Because it Gordon's type 3,
Huh?
better to
Garden 4. No, it's not. It's a Garden 3. No. The Garden classification, I was joking, it's not reproducible. So we don't tend to use the Garden. It's either displaced or undisplaced. So you could use okay, we have a displaced neck and femur fracture, okay. She's in her 40s.
Fracture line is vertical, sir. So it's the chances of failing osteosynthesis should be more.
Okay.
So rather than going for osteosynthesis, we can go straight away for a total.
Okay, we've got total hip replacement on my left. What are we going to do on this side of the room? Screws. Okay, that's not unreasonable. And if you were reducing this, and you couldn't reduce it properly, who would open it to reduce it?
So we can also do this valgus osteotomy.
What?
Valgus osteotomy.
Well, yeah, but not at the moment you wouldn't. It's day one, isn't it? Valgus osteotomy would be if it was a non-union or something.
No, if the case presents late.
Yeah, but we're talking about day, she just come into the hospital. Okay, so we're going to do screws, yeah? Should we do screws? Okay, let's do some screws. Oh dear. Oh dear. So here we are, about 2 months later. And she's got 3 sons, and they're all members of the gang, and they're very unhappy. What are you doing with my mother? Why is her hip like this? Okay, so let's have a look now. We can see she's got very... Okay. What are we going to do now anyway? We're going to revise it to what?
Still vertical, fracture line is vertical.
It's better to put a mini DHS in this case.
Yeah, right, we've got a DHS on my right. Okay.
With valgus also.
Who's going to do something different?
Pause osteotomy.
Pause osteotomy over on my left. This is a total hip course. That's the clue. Okay, so we know that with displaced neck and femur fractures, a high percentage will need a reoperation. Okay, keep it simple. You know, I wouldn't do any osteotomies in this lady. As I said, she's very big. She needs an operation to get her back on her feet and back on with her life. Huh? So what are we going to do? Yeah, what's it back?
Yeah. So because she is very obese and she wants to be on the feet earlier, then we go for a cemented THR, total hip replacement.
So we've got total hip replacement over here. Okay, cemented. Okay, well, should we try and do some pre-operative planning then? So if these screws are 6 millimeters, so the canal doesn't look so small, does it? Do we think there might be any problems? But they only had room for 2 screws in the neck. So she's a big lady, small bones. Okay, so you want to think about that. We might use some templates. Okay? So tell me about the technique then. What are you going to do? So when you are broaching or rasping the canal, you start off with a hand, you start off with the reamer first, yeah? Anybody put that on power? No? Good, okay, I thought in the video we might have seen it. Okay, so this was being done by an interesting surgeon. Shall we carry on? And during the operation, I got a phone call. Mr. Pierce, I can't get the brooches down. This lady's canal is really, really narrow. So, being an orthopedic surgeon, he continued to ream, okay, and took a lot of bone away. And he's perforated the femur, okay. The trochanter looks like it might be floating in the breeze. So, I wasn't in the hospital at the time, and I said, well, you know, leave it, and we'll manage it. Obviously, if she's got a very narrow canal, we might have to get a special prosthesis in. So what do we do now? Someone's got to go and speak to her 3 sons. They're really unhappy now. Okay? This really happened, actually. I meet her for the first time now. Family very unhappy. So what are we going to do? Huh? So long stem THR. Okay, so apparently the canal is really narrow. The x-rays aren't giving it away because we haven't got, as we heard this morning, we haven't got any calibration. So it's a very tight canal. Sorry? Approximately?
You know, the short stems ones.
Short stem, but look, you've got a defect here. She's a beast. You're going to put a short stem above a defect? She's got no, it's reamed out the canal. So you're going to have to go long.
If you use a short stem, it'll fracture.
Absolutely.
So if you use a short stem up to somewhere there, there's a gap there, that's fracture.
So what are we going to do? We need more knowledge, don't we? Huh?
This lady needs a metabolic workup.
Okay. Well, you can be the physician, but you can do the blood test. But what are we going to do? What are the surgeons going to do?
We need to get some sharp reverse diamond reverse.
Sorry?
Get some sharp reverse diamond.
Sure. Well, we haven't got to theatre yet. We haven't got to the operating room. We want more information about what size implant. How do we get that information? Templating. Okay. So how talk me through it then. What are you going to do? We've separated anything, have we?
We take a repeat X-ray with a normal side and put with a scale out.
Yeah, good. Okay. Or a CT scan is also useful. I mean, a CT scan is going to tell you your osseous anatomy. How much damage is there? That would be useful. And then an X-ray with a scale. Good. Okay. So that's what's done. You can see he's gone out the whole of the cortex, all down one side. Okay. That's not good, is it? So now we've got a longitudinal defect. There's our scale. Okay, I sent this off to the company. So they designed something for me. Okay, so what are we going to do about this defect?
Can do only bone grafting.
What sort of bone graft?
Allograft.
What sort of allograft? Huh? Okay, a strut graft, okay, to contain the defect, okay? So we thought about that, so we've ordered one of them. Now she really is, when we did the templating, this diameter is 38. Okay, the femoral head size was 38 millimeters. I mean, this is pretty small, huh? So now you can get cups that small. You know, 15 years ago when we did this case, it was hard to get those cups that small, but Charlie used to make one for congenital dislocation of the hip, where the polyethylene is offset superiorly, okay, but it's 38 millimeters external diameter. That was the smallest cup on the market at the time. Okay, let's keep going. So, and then I decided to do a polished, tapered, long stem with cement. In this particular case, again, in those days, it would have been very difficult to get a very narrow, uncemented stem. I've ordered my strut, which I'm going to cerclage wire, and then I'm going to cement everything. Okay? I mean, that was my plan. I think as long as you've got a plan, and you've got the kit, it doesn't really matter whether it's cemented, uncemented. Okay, we all happy so far? Okay. So, I was lucky. So, here we go. This is the offset. It's called the offset ball cup, but it's 38 millimeters. I think that's a 28 head. A bit of poly there. We've managed to get a bit of cement in there. There's the strut graft. A couple of wires around that, and it. You know, I've been in cases where custom implants won't go in, but we were lucky this one did. Okay, and I think we got the next picture is 18. Oh no, go back one. Okay, I think we can see it has united. That's the follow-up picture. You see the strut graft is united to the femur. Okay, well on that note, I think we'll bring today's session to a close. I'd like to thank Dr. Gupta for all his hard work putting this together for you, and I hope you enjoyed it.
Thank you very much, guys. I hope you all enjoyed, you benefited, you learned the safe principles of total hip replacement. I think taking this forward, we're hoping to have another course next year, hopefully by the Royal College in India. Of course, McPeers is going to be there then as well, and we'll have more detailed discussion then. Thank you very much.